Good afternoon. Thank you for inviting me to provide these presentations today. Today, we are going to discuss regarding the approach of chest pain. Here, I wanted to highlight mainly that acute chest pain, but Dr. Rohan is going to tell stable chest pain and its investigations. So, we'll start. Chest pain, why we wanted to highlight or wanted to focus this chest pain? Because the chest pain is the common presentations to our clinic, even ward, even everywhere. The patients comes with these problems for treatment. So we have to know how to approach and how to path the patient's problems. Even though there are many causes for the chest pain, the main problems or very detrimental problem is cardiovascular problems, that is cardiac ischemia. So amongst these all problems, we have to catch that and how to manage. So for that, we have to have a proper approach for the chest pain. So there are cardiovascular, pulmonary, gastrointestinal, and chest wall problems. They also can present with the chest pain. But in pediatrics, they may have some special problems. They may present with the chest pain. So all these problems should be known, and we have to extract from these detrimental factors. So in a patient with a chest pain, so to identify, to highlight whether it's a high-risk patient or it's a not high-risk patient, there are some pathways. So the basic idea is it's initially onwards there, that is any adult male more than 30 years and female patients after menopause, when they present with a chest pain, we have to think as ischemia until proved otherwise. Even though this pattern is disturbed nowadays, because now more younger generations are presenting with chest pain and even myocardial infarctions, this is a common criteria we have to think to work out. So the chest pain, mainly I wanted to tell there are 5 important factors about the chest pain, which we all know the basic fundamental things. The site of the chest pain and the character, as well as the radiations and the aggravating relieving factor and its associating features. So among which, the 3 main picture, the site with character and radiation and aggravating factor, these 3 are typical features of the chest pain for the angina. So with these classifications, they are dividing the chest pain into main 3 categories that are typical chest pain, atypical chest pain, and non-specific chest pains. If these all 3 are present, that is a typical chest pain. When these only two is present, it is atypical. 1 or less, it's non-specific. Why we wanted to classify that? We wanted to make or extract the proper patients towards very quick approach to identify the ischemic heart diseases. So the sites, it can be, upper chest, retrosternal chest pain, or it can be there in the intrascapular chest pain, the origin. The pain can radiate to the upper jaw or neck. It can go to the both arm or shoulder. So that is the classic site as well as the radiations. Other than that, the breathlessness. So due to the congestion of ischemia, the cardiac congestions, the patients also presented with the shortness or breathlessness. Some patients, for example, in elderly people as well as the diabetic patients for a long time, they are on treatments with proper control, or even chronic diabetes patients with the proper control. Their presentation may be differ or vary. They can only present it with the breathlessness, or they can present it with the sudden even cardiac arrest, because the pain might not be very typical in that populations or on that category of people. So the patients who presented with the breathlessness, they may almost equal presentations like exertional shortness of breathing, like exertional pain. So we are calling those people as angina equivalent category of people. So we have to think equally those people to investigate in the ischemia pathway. So as we all know, the angina, the classification of the angina according to the Canadian Cardiac Society classification, this is mainly they are telling the severity of the chest pain. So it can be class 1 to class 4 according to the severity. So with the sternus, if it is very severe pain on sternus exertion, the classification is 1. Even the pain is at rest is class 4. In between class 2 and 3 are there. Why it is important still for the screening, investigations as well as management as early as possible to arrive the diagnosis and cure the problem. So as we all know, when a patient presented with chest pain, we are not approaching only with one component. It's a collective of components we are assessing the patient with. So the heart classification still all these components, the history, which we discussed, that the pain site, radiations and its character, as well as the associating symptoms and aggravating factor, relieving factors. Those are mainly there in the history. And we have to know whether the patient had past event of the cardiovascular problems like MI or any stable ischemia. And it's also include the family history and other risk screening. And ECG. As we all know, there are some characteristic changes can happen when the patients with the cardiac problems. It can be ST elevations or non-ST elevation changes, ST depressions or T inversions. There are a lot of other changes also can happen. But in some people, the ECG also might be normal with the the typical chest pain. So that's also we have to have in our mind. And other than that, age, we know as we told earlier, and risk factors, these will be, I think, will be clearly explained by Ruan later. And troponin. These all tools we are using to identify their problems. So this is I just want to highlight the heart score. Why these charts and tools are there? Because in in centers, there are busy places. Even from the primary area, when the first contacts doctor, he has to salvage the patients towards whether it is patients need more investigations or are we going to send the patients back for outpatient basis investigations. For that, they are using these sort of charts like heart score. So our main purpose to identify the acute coronary syndrome in the case of the chest pain. So when I just wanted to tell the classifications, there are main 3 components in the acute coronary syndromes. Stemi, that is myocardial infarctions. When a patient with a chest pain with the ST elevations, yes, that is Stemi. That is we all know, that is even at the first context we are easily diagnosing and sending for the proper management. And other group is non-STEMI as well as the unstable angina. So when patient presented with a typical chest pain and ECG having non-ST elevation changes, it can be ST depressions or T inversions or other changes. And we have to go for the cardio biomarkers. So mainly nowadays we are checking the troponins. So if those criteria are positive, we have to make the diagnosis as non-STEMI. But when a patient with a chest pain as well as ECG changes, but negative cardio markers, we are calling as unstable angina. Why we have to make this classification is the treatment strategies are different according to the classifications. For example, in a patient with a STEMI, the management is, first management is the primary PCI, primary intervention. So if the facilities are not there, we have to make or thrombolysis the patient as early as possible. But non-STEMI and unstable angina, the management is different. We have to medically manage the patients and have to prepare the patients as early as possible to open the blocked vessels. The coronary vessels we have to open as early as possible. So this is the same things I wanted to put like in a picture. So here, as we all know, the classifications again, it's STEMI and non-STEMI. STEMI, the primary PCI, as we know, primary lysis. So the treatment for the STEMI is depend on the site whether the cath lab is there or not. So if it is there, within 2 hours, if the patient is able to arrive the cath lab, the first treatment choice is primary PCI. Primary means first, PCI means we have to do the percutaneous coronary intervention as a first treatment options. Why? We have to open the patient's coronary arteries because the patients presented with a heart attack, that means myocardial infarction, there are acute total occlusions of the coronary arteries, it causing the cardiac muscle damage. So with time, it going to be necrosis, and there is irreversible damage can happen. To prevent that, as early as possible, we have to open the vessels. For that, we can try medically or interventions. The medical treatment successful rate is in a streptokinase is only 40%, but RTPA and other newer drugs are around 60 to 70%. But in a patient with the primary PCI, almost the success rate more than 99%. So that's the reasons they are highlighting as primary PCI as the first choice. But where the patients are unable to reach these facilities, or if it is getting late to get the facilities, we have to give the medical thrombolysis. Thereafter, we have to send the patient for the as a rescue process. Sometimes, if the people's medical management is successful, we have to do the procedures before discharge. But in a patients who have a poor response for the medical treatments, we have to do as early as possible as a second option, as a rescue process. The next main thing is we have to tell a troponin. So troponin, I wanted to highlight some things. The time to time, the cardiac damage assessment is depend on some cardio biomarkers. So with the chest pain and ECGs, thereafter we have to confirm whether actually cardiac damage has happened or not. For that, initially onwards, there are many cardio markers used. It was AST, CPK and myoglobin, troponin. But troponin, up to now, up to 2010, the conventional troponin assay was done. That is called troponin C, troponin I. But later they have found in people, usually what we are doing after MI, we have to do the troponin level sometimes until achieve the usual identifiable value, it may be negative. So we have to wait for 6 hours to catch whether the patients had elevated these problems, and thereafter only we have to plan treatment in some sort of people. To reduce or minimize that problems, what they are doing, the high sensitive troponin level was identified or it is introduced from 2010. What is the advantage of that? Even mild elevation of the troponin level, we can identify with the these high sensitive assays. So when we are telling in normal populations also with the day-to-day cardiac, all the cell cycles are going on like that. Cardiac cell cycles also is going on. There is apoptosis, damage and minimal events are going on. Due to that, the minimal amount of troponin will be there in the blood. So, conventional troponin will not identify that sort of minimal amount of troponin, but in high sensitive, it can be identifiable. So, now the problem is which category of people are having actual cardiac problems. For that, we are having some criteria. So, if it is more than 5-fold, the possibility of myocardial damage due to the MI is high. But more than 3, the 50 to 60% of positive predictive values are there. So below that, it can happen, but we have to again monitor the troponin, because the cardiac damage is not a static process. It is a dynamic, it will go on. So what will happen, initially the troponin will be very minimal, but with time the amount can be very high. So there will be a wave-like pattern. In sometimes the other way around also happen in late presentation of the MI. So to identify exactly the pattern, the high sensitive troponin nowadays, it's very helpful. So this is the normal pattern of the troponin which is introducing in the blood. So in healthy young people, they may have a minimal amount. With the elderly and chronic disease people also may have a significant level of troponin. With the myocardial injury in the initial stage, it will be significantly high. With myocardial infarctions and necrosis, the amount will be huge. So which is we already discussed. The people with a positive predictive value, when it's more than 5-fold, is high in a patient with the acute MI. So the MI or cardiac injury, so when we are considering the cardiac injury or muscle damage, there are so many causes can cause the damage. One of the main problems is the myocardial infarction or acute coronary event. Other than that, there are a lot of other direct causes as well as relative oxygen ischemia also can cause the cardiac damages. So if we think, that's why they are telling the type 1 cardiac MI and type 2 cardiac MI means when there are blocks in the coronary vessels which causing the myocardial damage, that is type 1 cardiac damage. In a people who are having a relatively low oxygen level to the myocardium, it can be due to the high demand of the myocardium, but the provide of the level of the oxygen will be low. It can be tachycardia, systemic disease or any other disease, anemia, and so many causes can cause that. In those instances also can cause high level of troponin. So in a patient with a high troponin, it's indicating the cardiac damage, but the cause is not purely MI. It can be due to several other causes even. So I just have highlighted the causes of myocardial damages here. It can be arrhythmias, heart failure, hypertension, and other critical illnesses. Sepsis, this is the most common causes we are identifying in the ICU setup. Patient with the sepsis and burns and any other reasons due to infection or something causing shocks, also having a high troponin with mild ECG changes. And the other important cause is myocarditis. Myocarditis can be due to many factors. It can be infectious causes, toxic, or even it can be due to some drugs. And other important cause is Takotsubo syndrome, that means stress cardiomyopathy. So usually it can happen in people who are having stress-related events, mostly in a patient with the postpartum or during the delivery. So usual presentations, and they may have ECG changes following cesarean sections or normal vaginal delivery with a chest pain and may have a high troponin. So one of the main causes is the stress-related cardiomyopathy. There are other causes, even postpartum or peripartum cardiomyopathy, that also can cause. And other than that, structural heart disease and other pulmonary causes. The main cause is the pulmonary embolism. Massive pulmonary embolism also can cause right ventricular strain and high amount of troponin, and renal diseases also can cause. Other than that, in lab, there are so many techniques they are using. So there may be an error or there may be a problems identifying the troponin as well in the lab techniques. So mostly there will be a false high reports due to some reagents mismatch or error. So that's also we have to keep in our mind, because some patients may be asymptomatic. They may have some non-specific changes. For them, when we're doing, they may have identified high level of troponin. So we can't jump and treat those patients as an acute coronary event. We have to have a good pathway to salvage those people, because some investigation process also harmful, because angiogram and everything. So we can't send every people for all investigations. So due to that, they are telling now even 2020 ESC guidelines, they are keeping the high troponin assay as one of the main tool. We have to do it in a first presentation as well as after 1 hour, 2 hours, 3 hours, but mostly 3 hours measurements they are recommending to identify the ongoing cardiac damage. So according to these issues, we are planning the management. So For the management, we all know patient present with a non-STEMI. So, and STEMI, as we all know, STEMI management is, we all discussed earlier, but non-STEMI and unstable angina, the purpose, whether this event is very serious or it is a very large, it has happened or it has occurred greatly impact, or whether it is a minor level of problems. So that's why we have to assess the risk of the patients. So for that there are a lot of tools. I don't want to tell very clearly everything here. Main things the ESC guidelines introducing is a GRACE score. The components are here: age, heart rates, and blood pressure, and CLIP score, that is the systemic or the clinical assessment of the cardiac failure, creatinine level. So those components we have to assess. For example, in a patient with more than 60 years have a tachycardia or arrhythmias, we have to think that patients having a high risk with comparing of younger patients with a stable heart rate. So in that patients, even though we are thinking yes, young patients, we have to do as early as possible the intervention, we have to think that patient also, because he is in a risk. So we have to give priority for them, and this patient is relatively stable, we have to have a plan after that. So for that, we have to have a score. So main score we are using is a GRACE score. So I don't want to tell each and everything very in a deep manner. So more than 140 roughly, it's having a high risk GRACE score. So, and for that, those are the main structure of this approach of the chest pain. This is, I just wanted to tell a case. This is the patient actually presented with a chest pain, and this is when we are seeing this patient's presentation is the chest pain, and troponin may be not very high. This patient's troponin is very limited elevations. So when the troponin is very high, what we can tell, the cardiac damage is high, that is proportion. But when the troponin level is very low, we have to think whether, mostly it is not a very big problem, but one or two things can happen. It's like a time bomb. Here this patient presented with the typical chest pain, and the ECG changes is like this. So what will happen, the troponin we will do, troponin only marginally elevated. So we can't think whether it is only a small issues. We have to send the patients as an outpatient basis. This is syndromes usually we are telling as a Valence syndrome, because these patients having a 99% of block usually having in the left anterior descending artery. They are more prone to get a very extensive MI within usually 2 to 3 weeks or months. So we have to take these patients, or we have to give more priority this patient for the interventions. For one of the patients present initially like this and as MI, I wanted to show the angiogram. For this patient we did the procedures. This is the patient presented with the chest pain. So initially his presentation is like the initial ECGs which I saw, but after 1 week he developed anterior MI and got admitted to our hospital, and the patient was treated with the medically and sent. But within again 1 week he developed re-infarctions. Thereafter we get the patients to the cath labs, and the angiogram was performed. So this is the angiogram. When we see this angiogram, there are two main vessels here, the left side. This vessel is circumflex artery, and this one is left anterior descending artery. The other view I can show it clearly. this left anterior descending artery, there is a block that is around almost near total occlusion, around 99% of block is there. So what we have to do, this patient's only medical management might not enough. So this patient needed interventions and parallel medical management, which was happened patient. So this patient, it's getting wired first initially, and later that is the area it was tended. So I don't want to open every stent because it takes time. So I just wanted to highlight these slides because here we have, this is the area the block was there, and after stenting the flow was established as a normal pattern. So this is a patient with the acute coronary syndromes who following with the repeated or recurrent anterior MI. So there was another patient who presented with the anterior MI. In that patient also, I think, is there any time shall I put another CD? Dr. Sandip, shall I put another CD? Is there time? This is actually another patient presented with the chest pain with the ST elevation in the anterior leads. This is the angiogram, first angiograms when we do. And when we saw that the LCX, as we showed in the previous angio, it is there, but LAD is totally gone. The other right side coronary artery is having only mild diseases. So in these patients also now, after wiring, the flow is establishing. This is the vessels initially was totally occluded, and even after wiring, that's why now they are including the wire time So when we wire, the flow is re-establishing. So the myocardium which was is in ischemia will get the supply, and the chances of the necrosis will be low. So this is after wiring, and this is a vessel was initially totally not seen due to the total occlusion. And after that, the patient was stented. I wanted to highlight very quickly and finish. This is just ballooning. And now this is the stent, as you all know we are stenting, and after that now the flow is establishing, but there are some slow flows, but with the medicines the flow is established about near normal levels. So this is, I just wanted to highlight because we wanted to know what's actually happening in the primary PCA or something. That's wanted to highlight the both series. So I wanted to conclude with that. So the chest pain is very important to analysis in a methodical way to identify the detrimental problems of the ischemic heart disease as early as possible. So that's my take home message. So I want to conclude this. Thanks.